after the transplant. So they are not preformed. These antibodies are formed after the transplant. So this is a type 2 hypersensitivity reaction. So if it is acute cellular rejection, this will respond to increasing the dose of immunosuppressive therapy. If it is acute humoral rejection, this does not respond to increasing the dose of immunosuppressive therapy. It does not respond to increasing the dose of immunosuppressive therapy. Then what does it respond to? So what is the treatment given for this? Treatment is you give them B cell depleting agents. B cell depleting agents. So you are removing the B cells because the B cells are the ones which are producing the antibodies. So give them B cell depleting agent. Antibody produced against the graft will be reduced. Okay. Now microscopy, what do you see in this acute cellular rejection? Acute rejection. What is the microscopy? In whether it is humoral or cellular, what do you see? It is basically again the blood vessels of the graft are inflamed. So there is vasculitis of the graft vessels. So what do you see? You see vasculitis of graft vessels. So we see vasculitis of graft vessels with, in the kidney. If you look at in the kidney, number one, the blood vessels will be inflamed. So vasculitis of the graft vessels, and two, in the graft there is dense interstitial lymphocytic infiltrate. With dense interstitial lymphocytic infiltrate. So you see vasculitis of graft vessels with dense interstitial lymphocytic infiltrate. So with dense interstitial lymphocytic infiltrate. So this is the microscopy, vasculitis of the graft vessels with dense interstitial lymphocytic infiltrate. So this is acute rejection, which is of two types, acute cellular and acute humoral. Acute cellular rejection is a type 4 reaction where the CD4 and CD8 T cells will damage the graft. So recipients CD4 and CD8 T cells will go and they will recognize they will damage the graft. And second is acute humoral rejection, where the recipient starts producing antibodies against the graft. These antibodies go and damage the graft, but these antibodies are produced after the transplant. They are not preformed antibodies. Preformed antibodies are going to cause hyperacute rejection. Okay, last type of graft rejection is chronic rejection. Chronic rejection. The most common type of graft rejection today is chronic rejection. Chronic rejection happens from months to years. So it happens from months to years. So chronic rejection happens from months to years. And this chronic rejection can be both cellular or humoral. It can have both cellular. So it can be both cellular that is involving the T cells, that is type 4 hypersensitivity reaction, or it can be humoral also. Humoral, that means type 2 hypersensitivity reaction. So it can be both cellular or humoral graft rejection. And the important features. So on microscopy now, chronic rejection is dominated by vascular changes. So it is dominated by vascular changes. That's again changes in the blood vessel, vascular changes. Okay, what are the changes that you see? Okay, now in the blood vessel wall, in the blood vessels, if you look at a blood vessels have three layers: intima, media, and externa. Or the media is the middle layer, and it has the muscle. So now what do you see? It is dominated by vascular changes. What do you see in the blood vessels of the graft? There is number one, proliferation of vascular smooth muscle. Proliferation of vascular smooth muscle. Second, so the blood vessels become very thick because the smooth muscle in the media proliferates. And the blood vessels can close also, or they can get obliterated also. Second, there is the parenchymal, that is, second, all the glomeruli undergo sclerosis. There is glomerulosclerosis. 3. Tubules undergo atrophy. So there is tubular atrophy. So glomerulosclerosis, tubular atrophy. 4. Interstitial fibrosis. Interstitial fibrosis. So in the interstitium of the kidney, grafted kidney undergoes fibrosis. The tubules of the grafted kidney undergo atrophy. The glomeruli undergo sclerosis. And in the blood vessels, the vascular smooth muscle is proliferating. And it is dominated by vascular, there is arteriosclerosis. 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 Okay, examples. Let us see organ-specific examples. Organ-specific examples of chronic rejection. Organ-specific examples are, number 1, chronic rejection in the lungs can lead to, chronic rejection of lung graft can lead to bronchiolitis obliterans. Bronchiolitis obliterans in the lungs. So in the lungs, chronic rejection, if chronic rejection happens, okay, Sridevi, I should drink water, you are right. Okay, so in lungs, organ-specific examples are, in lungs you have bronchiolitis obliterans. Then in examples in the heart, accelerated atherosclerosis. Atherosclerosis in the heart vessels. Accelerated atherosclerosis. Third, chronic in kidney. In case of kidney, the whole story that I have told you, this whole story about kidney, this is called chronic graft nephropathy. So in kidney, you have chronic allograft nephropathy. Yes, graft nephropathy. So in example in kidneys, chronic graft nephropathy, and in case of liver, vanishing bile duct syndrome. So vanishing bile duct syndrome in the liver. So accelerated atherosclerosis in heart, bronchiolitis obliterans in lung, vanishing bile duct syndrome in the liver. All these are examples of chronic graft rejection. Okay, so now this finishes transplant rejection, graft rejection. Next entity in transplant pathology is GVHD. What is GVHD? GVHD stands for graft versus host disease. GVHD stands for graft versus host disease. Graft versus host disease, GVHD is a type 4 hypersensitivity reaction. It's a type 4 hypersensitivity reaction. Okay, now what is the concept of GVHD? Now GVHD, you know, this is seen in, number 1, in organs. If you transplant organs which are rich in lymphocytes, GVHD can occur. Which are these? So seen in organs, in transplantation of organs rich in lymphocytes. So in transplant of organs rich in lymphocytes. So this is seen when you transplant organs that are rich in lymphocytes, like bone marrow transplant. So it's a complication of bone marrow transplant or liver transplant. So bone marrow transplant, or common is bone marrow transplant or liver transplant. So in organs that are rich in lymphocytes, like when you do a bone marrow transplant and when you do a liver transplant, this complication, that is graft versus host disease, can occur. Okay, now what happens in GVHD? Now here let us see the concept. For example, this is the recipient, and this recipient, and this is the bone marrow that has to be transplanted. So this is the donor marrow. This is the donor bone marrow. So this is the bone marrow transplant. Okay, now this recipient here now is immunocompromised. In case of kidney transplant, which I showed you, transplant rejection, what was the concept there? The recipient was immunocompetent, and if he liked the graft, he kept it, otherwise he rejected it. Here now the concept is ulta. Here the recipient is immunocompromised. He is immunocompromised due to the primary disease for which he is getting a transplant. For example, whom do you give a bone marrow transplant? Say you have a child of acute leukemia. Okay, I'll explain again, Adesh. Okay, now let us come. Okay, now graft versus host disease. It's a type 4 hypersensitivity reaction 1, and this is a complication seen in organs rich, when you transplant organs that are rich in lymphocytes. If you are giving example, which are the organs rich in lymphocytes? Number 1, bone marrow is rich in lymphocytes. So if you are giving a bone marrow transplant to somebody, this complication can occur. Second, liver transplants are rich. Okay, now here first concept understand, say this is a recipient who needs a bone marrow transplant. Okay, he needs a bone marrow transplant, and you know this bone marrow transplant is rich in lymphocytes. So this is a donor bone marrow which is rich in lymphocytes. Okay, now the recipient here is immunocompromised in contrast to transplant rejection. So this is transplant rejection. What did I first tell you? In transplant rejection, I told you somebody needs a kidney, you want to give a kidney. The recipient is immunocompetent, his immune system is perfect, his B cells, T cells, everybody are perfect. This kidney comes here. If his B cells, if his immune system, B cells, T cells like the kidney, they keep it. If they don't like it, they reject it immediately. Hyperacute rejection, which is due to pre-existing antibodies, acute rejection or chronic rejection. Okay. Now, in organs that are rich in lymphocytes, there they have a problem called GVHD, which is a type 4 reaction. What happens in which are the organs rich in lymphocytes? Bone marrow and liver transplant. Okay. So now say this is a recipient who needs a bone marrow transplant. Here now the recipient's immune system is not okay. The recipient is immunocompromised because due to the primary disease. So due to the disease, so this is a recipient who needs a bone marrow transplant. Why are you giving him a bone marrow transplant? Because he has acute leukemia. Acute leukemia is making this recipient immunocompromised. Second, so they are immunocompromised due to their primary disease, or they are immunocompromised due to chemo or radiotherapy. Radiotherapy which is given to form the transplant bed. Which is given to form transplant bed. Transplant bed. So if this is a child of acute leukemia, he needs a bone marrow transplant. His leukemia makes him immunocompromised. Second, before giving him a bone marrow transplant, you will kill all the leukemic cells in his bone marrow, and even the normals. You will kill all his leukemic cells, or you will destroy his bone marrow by giving him chemo and radiotherapy, and thus you will form a transplant bed, and then you will give this bone marrow transplant. Now, what does this bone marrow transplant contain? This bone marrow transplant, number 1, it has stem cells. Plus, it is also rich in lymphocytes. Why does it have stem cell? Why are you giving stem cells? So now this bone marrow transplant will come in the recipient, and the stem cells will start regenerating the marrow. What will the stem cells do? They'll start regenerating the marrow. But these donor lymphocytes, plus there are donor lymphocytes here. So there are donor stem cells. Donor stem cells are good people. They'll start regenerating the marrow. But these donor lymphocytes, they are bad people. They are responsible for GVHD. What will these donor lymphocytes do? These donor lymphocytes will get up from the bone marrow, will get up from here, and they will travel in the entire body of the recipient. They will go to the recipient. So recipient, poor thing, is immunocompromised. So these donor lymphocytes which have come from the donor, which have come with the donor bone marrow transplant, they will get up from there and they will circulate in the body of the recipient. They will recognize the recipient's tissues as antigenic, and these donor lymphocytes will start causing damage to the recipient's tissues. So they will cause damage. So they will these T cells, these donor T cells are the culprits. The donor T cells will, in this immunocompromised recipient, the donor T cells are going to recognize the recipient's tissue as foreign, and they will lead to severe type 4 hypersensitivity reaction. So what is the pathogenesis here now? What is the pathogenesis? Pathogenesis is the donor T cells which have come with the graft, So what have come with the donor stem cells? So in the donor bone marrow, what do you have? You have the donor stem cells and you have the donor lymphocytes, T lymphocytes. So the donor T cells which have come with the graft, these donor T cells, what are they going to do? These donor T cells, they recognize the recipient tissues. tissue as alloantigenic. Alloantigenic. So they recognize this recipient tissue as alloantigenic or foreign. Recognize this recipient tissue as alloantigenic and foreign and they mount a severe type 4 hypersensitivity reaction and thus cause destruction. So they recognize, recipient recognize the immunocompromised recipient tissue. So recipient is already immunocompromised, his own immune system is 0, and these donor T cells come and they recognize all his tissues as foreign and they start mounting a severe type 4 hypersensitivity reaction. So now, these donor T cells, they circulate everywhere in the body of the recipient. They go to the skin, they recognize the skin as foreign, start damaging the skin cells. They go to the GI tract, start recognizing the GI tissue as foreign, start mounting an immune response. They go to the liver, they go to the spleen. So now what do you see? So now the number one, in the skin, you see a the recipient develops a maculopapular rash. Maculopapular rash. So GVHD is divided into acute. It's divided into acute and chronic. So GVHD is divided into acute and chronic. So in acute, you see a maculopapular rash. And when this rash heals, there can be scleroderma-like fibrosis. Scleroderma-like fibrosis. So when this rash heals, there can be a scleroderma-like fibrosis in the skin. Second, in the GI tract, there are esophageal ulcers. They develop esophageal ulcers. Malabsorption, diarrhea. Malabsorption, diarrhea. And when these ulcers heal, there can be strictures. Esophageal strictures can be produced. Third, liver. In the liver, there is liver and spleen. There is hepatosplenomegaly. And they develop jaundice. There is jaundice. Bile ducts are damaged. So there is jaundice. So there is bile ducts are damaged. There is jaundice. Then there is also destruction of thymus, lymphoid organs, destruction of thymus, lymph nodes, etc. All are also. So the donor T cells go around destroying everything. So it is divided into acute and chronic. So acute is usually we say less than 100 days. So acute graft versus host disease is less than 100 days. Chronic is more than 100 days. So chronic is more than 100 days. Okay. So this is seen in this transplant. So this is about graft versus host disease. So concept here is the recipient is immunocompromised. The donor T cells come and the donor T cells recognize the recipient tissue as alloantigenic and start mounting an type 4 hypersensitivity reaction and start causing destruction. So this is graft versus host disease. Okay. So now this finishes with the chapter of immunopathology. So in immunopathology, whatever I have to cover, this finishes immunopathology. I'll be starting neoplasia. So before that, let's look at a few questions. Okay. So let us look at a few questions. Okay, quickly. Okay, this much I had covered. Okay, look at this. A 7-month-old girl. So please look at this question. Hello. हाँ जी बोलिए. Okay, so look at this question. A 7-month-old. So answer to this question, a 7-month-old girl is brought to his pediatrician's office due to concern for recurrent infections. The parents state that over the last 3 to 4 months, the boy has multiple viral respiratory infections along with fungal pneumonia requiring hospitalization. Currently, he is without complaints. However, the parents are concerned that he continues to have loose stools and is falling off of his growth curve. Newborn screening is not recorded in the patient's chart. On examination, patient's temperature is 98.5. Blood pressure is 100 by 68, pulse is 90, and respiratory is 12. The patient is engaging appropriately and is able to grasp, sit, and is beginning to crawl. However, the patient is at the 20th percentile for length and weight, and he was previously at the 50th percentile at 3 months of age. Further screening suggests that patient has an autosomal recessive immunodeficiency associated with absent T cells. Which of the following is associated with this disease? So what do you think is the answer? So it is autosomal recessive deficiency. So what do you think? Okay, last two points. Further screening suggests that patient has an autosomal recessive immunodeficiency associated with absent T cells. And you know that there is failure to thrive, if you see, over the last 3 to 4 months. So it's a 7-month-old boy. Okay, boy or girl here won't. Yes, very good, Sridevi. This is kid. So now, you know, there are two options. So this whole history, failure to thrive, recurrent viral infections, fungal infections, all these. So multiple viral and fungal infections, failure to thrive, the child is not growing properly, and all these things, they are pointing towards SCID. Okay, now you know SCID can be, okay, very good, Adesh. This is A, accumulation of deoxyadenosine. So this is SCID can be answered non-functional comma, two options. You have A and E. A and E. Both are answers for SCID. But here in the history we are giving you, it's an autosomal recessive. So the non-functional gamma chain subunit variety of SCID, this is X-linked recessive and will occur in the male child. Whereas here we have given you the option that it is autosomal recessive. So autosomal recessive variety of SCID is ADA deficiency. In ADA deficiency, deoxyadenosine will accumulate in the lymphocytes and kill them. It is, boy is written here just to confuse you. So autosomal recessive disorders occur equally in both males and females. Okay, in both males and females. Okay, Rishita, you want in GVHD. Okay, you want in GVHD, you want the last point. Okay. Last point in GVHD is, last 2 points, liver and spleen. There is hepatosplenomegaly, plus there is jaundice, and there is destruction of thymus, lymph nodes, etc. So lymphoid tissue is also destroyed. So thymus is destroyed, lymph nodes are destroyed. Okay, so now answer to this question is accumulation of deoxyadenosine. So this is autosomal recessive type of SCID. Non-functional common gamma chain subunit, this is the X-linked recessive type of SCID. Okay, now look at the next question. A 3-year-old boy is brought to emergency department after having 4 days of runny nose, low-grade fever and general malaise. This morning he started to experience shortness of breath with coughing and purulent sputum. So shortness of breath with coughing and purulent sputum. Okay, the mother states that she is particularly concerned since the patient has already had 3 episodes of bacterial pneumonia. So the child is having pneumonia. Again, the child is having pneumonia now during his lifetime, along with 2 episodes of viral gastroenteritis requiring hospitalization and IV fluids. So number 1, there's bacterial pneumonia. So there's respiratory infection. 2, viral gastroenteritis is also there. So enteroviral infection is there. On examination, the patient's temperature is 101. So he has fever. His blood pressure is 88 by 58, which is low. Pulse is 100. Respiration is 18. The patient is actively coughing with crackles heard all over the lower chest. So he has pneumonia. There are no palpable lymph nodes, but the examination is also notable for absence of tonsils. So his tonsils are absent. So the patient is stabilized. Blood testing and flow cytometry shows IgA is undetectable. IgE is very low. G is very low. M is very low. CD3 positive cells are normal. CD19 positive cells are reduced. Okay. So fish demonstrating 22q11 deletion. Anaphylaxis to blood transfusion. Western blotting demonstrating no expression of specific tyrosine kinase. Inability to repair DNA. Defective protein expressed on T cells. Defective protein expressed on T cells. So what is the answer to this? Okay, anyone else? Aishri Devi, I have seen your answer. Anyone else? What is the answer to this? Anyone else? Okay, now Sridevi, please look at the question again. Number one, the child is having pneumonia, and also the child is having viral gastroenteritis. Viral gastroenteritis. Okay. So the child has viral pneumonia, gastroenteritis. All the antibodies are reduced. Please see, IgA antibodies are undetectable, E is low, G is low, M is low. Then CD3 positive cells are normal. So what are CD3 positive cells? T cells are normal here. T cells are normal. CD19 positive, who are CD19 positive cells? B cells are decreased. So his B lymphocytes are decreased. Okay, fish demonstrating 22q11 deletion. This is a feature of DiGeorge syndrome. In DiGeorge syndrome, you have T cell immunodeficiency. But in this child, the T cells are normal, B cells are reduced. Anaphylaxis to blood transfusion is seen in IgA deficiency. But if you see this question, in this child, even IgG, IgE and IgM, it is a male child in whom all the antibodies are less. Not just IgA. IgA is undetectable, but other antibodies are also not there. And the number of B cells are markedly reduced. His B cells are reduced. Inability to repair DNA, option D. This is seen in ataxia telangiectasia. Inability to repair DNA, it's a feature of ataxia telangiectasia where only IgA antibody will be reduced. Okay. Then defective protein expressed on activated T cells. This is again another answer to this is C. Western blot demonstrating no expression of specific tyrosine kinase. So this is a 3-year-old male child. This is Bruton's A gamma globulinemia, which is A gamma globulinemia, which is seen in Sridevi, in ataxia telangiectasia, IgA antibody is predominantly decreased. Okay, so this is not ataxia, it is a male child, and there's a past history of recurrent. The child is 3 years old, but already he has 3 episodes of bacterial pneumonia in his lifetime plus viral gastroenteritis. So his antibodies are deficient. You know, antibodies, IgG antibodies, they fight these bacterial infections and also enteroviral infections. So this is Bruton's A gamma globulinemia. So where there are mutations in BTK gene, B cell tyrosine kinase gene. So BTK enzyme is not there. So Western blot will show no expression of this specific BTK enzyme. And all his antibody levels are decreased, plus the B lymphocytes are also decreased. So what happens in Bruton's A gamma globulinemia? Pro and pre B cells fail to get converted to B cells. So there are no B cells, no plasma cells, no antibodies, or very less B cells, very less plasma cells, very less antibodies. So CD19 positive B cells are not there. They are very low. They are markedly reduced. So Western blot demonstrating no expression of specific tyrosine kinase. But then look at question 11. A 56-year-old male undergoes a pancreaticoduodenectomy for resection of tumor in the head of the pancreas. His medical history is otherwise insignificant except for series of minor respiratory and GI infections since childhood that were effectively treated with antibiotics. So this is important. First, look at the age. It is 56. Second, there were minor respiratory and GI tract infections were there, but they were effectively treated with antibiotics. But today, he has not had any prior surgery or required a blood transfusion. So before today, so he has never had any surgery in the past. He's never got a blood transfusion in the past. In the post-anesthesia care unit, his hemoglobin is 5.2. So his hemoglobin is very low. He has severe anemia. So a transfusion of 2 units of packed cell is ordered. Minutes after the transfusion is initiated, patient reports severe itching, nausea, shortness of breath. His vital signs show a drop in blood pressure from 138/88 to 92/47. His heart rate increases from 94 to 118. The patient's nurse stops the transfusion immediately. What is severe itching, nausea, shortness of blood, BP falls down, pulse increases, he is developing a reaction. Okay, and itching Itching and nausea and shortness of breath, he's developing an anaphylactic reaction. Anaphylactic reaction. Which of the following underlying condition is most likely predispose this patient to develop this reaction? So what is the answer to this? So he has developed anaphylaxis to blood products. He's otherwise okay, except that he used to have this minor respiratory and GI infections in childhood. So what do you think this is now? Answer? Yes. Now this answer is E, selective IgA deficiency. So you know, most common primary immunodeficiency disease is selective IgA deficiency. Selective IgA deficiency, usually patients are asymptomatic, or they may have these mild minor respiratory and GI tract infections, and they can develop anaphylaxis to products containing IgA. So till now he's never required a transfusion. Now when he's suddenly given a blood transfusion, he develops anaphylaxis to this IgA containing product. So answer is selective IgA deficiency. So yes, Adesh, you are right. Okay, next, a mother brings 10-year-old girl to pediatrician for routine visit. During the visit, the girl comments that she recently has been having difficulty with her balance. So it's a 10-year-old girl and is falling more than usual. She also complains of rash on her face that has not resolved despite having multiple over-the-counter treatments. So she has a rash on the face. Second, she has difficulty in balance. The pediatrician is concerned and pursues a full workup which shows a high alpha-fetoprotein level. AFP levels are elevated. Which of the following is responsible for patient's symptoms? So what do you think? So this whole story, difficulty in having balance, falling more than usual, rash on the face, and raised AFP levels. This is the story of ataxia. Because of ataxias, he has difficulty with the balance. Telangiectasia, where she's developed a rash, she's developed those telangiectatic vessels on her face. So answer is E, that is defect in DNA repair. So what is the answer? Answer is E, that is defect in DNA repair. So what is answer E? Answer is E, defect in DNA repair. Okay, so yes, this is E. So answer is E. So in ataxia telangiectasia, there is defect in DNA repair. So defect in repairing double-stranded DNA breaks. Okay, now look at this. Okay, a 56-year-old woman comes to the clinic for post-operative follow-up appointment. She had undergone a liver transplant 3 months ago for cirrhosis secondary to autoimmune hepatitis. The patient is complaining of nausea. So there is nausea, abdominal cramps, diarrhea for the past 2 weeks. She denies vision changes, chest pain. Okay, Asha, you've asked me where can we get these questions. Okay, Asha, first of all, you've got a question bank from DAMS. Yes? Please solve that question bank. Okay, you first solve that question bank, which is there from DAMS, and then you can go. Okay, so first solve that question banks, and then you have those other question banks for MLE, you can solve them. But first, at least as we are covering your syllabus, start solving the DAMS question bank and then go over to the other MLE question banks that are available. Okay, and ask Dr. Mala, she's the best person who will guide you. Okay, about from where to pick up the right questions, ask Dr. Mala. Okay, so a 56-year-old woman comes to the clinic for post-operative follow-up appointment. She has undergone a liver transplant 3 months ago for cirrhosis secondary to autoimmune hepatitis. The patient is complaining of nausea, abdominal pains and diarrhea for 2 weeks. She denies vision changes. Sridevi, no DAMS QBS. Okay, you please talk to Dr. Mala. I'll also talk to her. Okay. You talk to Sridevi, talk to Dr. Mala, because there is a DAMS question bank for USMLE. Okay, so ask her how to access it, and second, she will tell you about the other question banks also, which you can refer. Okay, So she denies vision changes, chest pain, vomiting or urinary symptoms. When asked if anything could have brought on the symptoms, she reports that she was stung by a bee 1 week ago. She is currently taking tacrolimus and mycophenolate. You know, tacrolimus and mycophenolate, they are given to transplant patients. They are a part of immunosuppressive therapy which is given to the transplant patients. A physical examination demonstrates overreactive bowel sounds, abdominal tenderness, especially in the right upper quadrant, and rash. Okay, forget the figure, and rash. And the patient also has a rash. Okay, what is the most likely explanation for this patient's symptoms? Medication side effect, type 1, type 2, type 3, type 4 hypersensitivity reaction. Okay, yes, Sridevi, you are right. So now this whole story, number one, she's got a liver transplant. Okay, now I told you the two organs that are rich in lymphocytes are liver and bone marrow. So when they are transplanted, a common complication that you see is graft versus host disease. What happens in graft versus host disease? It's a type 4 hypersensitivity reaction. And in GVHD, yes, so answer is E, type 4. In GVHD, number one, GI tract is affected. So there's malabsorption, there's diarrhea, there is jaundice because liver gets involved. Then because of there's abdominal tenderness as it is shown, there is this rash, they develop a maculopapular rash, and overactive bowel sounds because of GIT problems. So this is whole story of graft versus host disease. So it's a story of acute graft versus host disease. So this is acute GVHD which the patient has developed. So 3 months back she had a liver transplant. So this is GVHD which the patient has developed. So answer is E. Okay, then let us look at next. A 45-year-old female is undergoing a renal transplantation for the management of chronic renal failure secondary to glomerulonephritis. The transplant surgeon placed the donor kidney in the recipient and anastomosed the donor renal artery to the recipient's external iliac artery as well as the donor ureter to the recipient's bladder. After removing the clamps on the external iliac artery, the recipient's blood is allowed to perfuse the transplanted kidney. Within 3 minutes, the surgeon notes that the kidney does not appear to be sufficiently perfused. Upon further investigation, an inflammatory reaction is noted that led to clotting off of the donor artery, preventing blood flow to the transplanted kidney. Which of the following best describes the pathophysiology of this complication? So what are we talking about here? This is happening on the operation table itself. So what is this? Within 3 minutes, this is happening. So what is this? This is hyperacute rejection. Hyperacute rejection. So what is this? Hyperacute rejection. And hyperacute rejection is which hypersensitivity reaction? So this is a hyperacute rejection. So I've just covered. So which hypersensitivity reaction? So yes, very good, Asha. Answer is B. It's a type 2 hypersensitivity reaction. No, Sridevi, it is a type 2 reaction. This type 1 is an allergic reaction. This is not an allergic reaction. So it is a type 2 hypersensitivity reaction. It is happening on the operation table itself. It's a hyperacute rejection. Hyperacute rejection is a type 2 hypersensitivity reaction. Okay. Then next question. A 62-year-old woman with history of uncontrolled hypertension undergoes a kidney transplant on 1 month following the surgery. So now here it is 1 month. Following the surgery, she has elevated blood urea nitrogen and creatinine, and patient complains of fever and arthralgia. Her medication include tacrolimus and prednisolone. Again, immunosuppressive therapy. If the patient were experiencing acute cell-mediated rejection, okay, which of the following would you expect to see upon the biopsy of the transplanted kidney? So what will you? Okay, so what will you see in the transplanted kidney? So what is the answer to this question? So now this is acute cellular rejection. So what will you see? So in acute rejection, I told you the microscopy. In acute rejection, what will you see? In acute rejection, number one, there is vasculitis plus Interstitial infiltration by lymphocytes, very important. So answer is B, lymphocytic infiltrate in the interstitium and the tubules. Lymphocytic infiltrate in the interstitium and the tubules. Okay, so answer is B. Yes, very good, Adesh, Asha. Answer is B, lymphocytic infiltrate in the interstitium and the tubules. Okay, so this we can leave. Okay, so these are about the questions on the transplant. So now I have finished this. Now let's start with the next chapter, and that is, let us start with neoplasia. Okay, so we'll start with neoplasia now. Okay, so now let's come to the next chapter, neoplasia. Okay, what does the word neoplasm mean? Okay, so yes, very good, Sridevi, it is lymphocytic infiltration. Okay, what is neoplasia? Neoplasm. What is neoplasm? Neoplasm is a tumor. Neoplasm is a tumor. What is tumor? You know, always remember there are two words called monoclonal and polyclonal. All our cells, our tissues are polyclonal. If something is monoclonal, if all these cells are monoclonal, monoclonality is equal to tumor. So tumors are monoclonal. That is, there is one transformed cell which goes on multiplying, producing its clone, and that forms a tumor. So what is a neoplasm? What is a neoplasm? It's an uncontrolled clonal proliferation of cells. So what is a neoplasm? It's an uncontrolled proliferation, uncontrolled clonal means here monoclonal, uncontrolled clonal proliferation of cells. So what is a tumor? Tumor is an uncontrolled clonal proliferation of cells, and tumors can be benign. Tumors can be benign or they can be malignant. So what is a tumor? What is a neoplasm? It's a tumor. It's an uncontrolled clonal proliferation of cells, and tumors can be benign or malignant. Okay, now before we look at tumors, there are two terms that we have to understand. Okay, that is, what is dysplasia? What is dysplasia? What is carcinoma in situ? What is invasive carcinoma? What is metastasis? These are few terms. First, let us look at number one. First, look at normal cells. Normal cells. Okay, look at, for example, let us look at the skin. You know, epidermis. Look at the epidermis. You know, epidermis is lined by stratified squamous epithelial cells. You know, say this is the basement membrane. This is basement membrane. Now, in the skin, what do you have? I'm drawing the epidermis. In the epidermis, what is epidermis lined by? It is lined by squamous cells, stratified squamous cells. Okay, how do they look like? These are the stratified squamous cells. These are all what I am drawing are stratified squamous cells. Okay, so now what do you see in these cells? Number one, all these cells are sitting nicely on a basement membrane. Where are they sitting? They are sitting nicely. Sridevi, clonal or monoclonal means the same thing. Monoclonal means there is one cell and all the other cells are the clones of that cell. So that one cell goes on multiplying and produces its clone. So that becomes a tumor. So that is monoclonal. So there is one transformed cell and that transformed cell starts producing its clone. Its clones form a mass that is called a tumor. So clonal or monoclonal, I mean the same thing. Okay, now these I have drawn normal cells. All these normal cells, they are sitting on a basement membrane. Look at these normal cells. These normal cells, they have basal to apical differentiation. So from the base, as they go upwards, they are differentiating. So these normal cells, number one, they have basal to apical differentiation, orderly differentiation. So in an orderly manner, they are differentiating from base to apex, from down above. Second, these cells, they have small NC ratio. They have small NC ratio, or they have normal NC ratio. That means, what is this? They have a small NC ratio. Normal NC ratio means nucleus. Now, what is the normal NC ratio? Normal NC ratio is 1:4. So, what is the normal NC ratio? 1:4. That is size of nucleus. If it is 1, cytoplasm is 4 times. And the cytoplasm is 4 times. And third, So these cells are normal. They have normal differentiation. What do you mean by normal? Basal to apical differentiation. They are sitting one on top of other and differentiating from below upwards in a very orderly fashion. And two, the cells have a small nucleus and the cytoplasm is 4 times the nucleus. Okay, so these are normal cells. Okay, now what is dysplasia? So second term now we have is dysplasia. Dysplasia. Again, now look at dysplastic cells. Now dysplasia, again there is a basement membrane. There is a basement membrane. These cells are sitting on the basement membrane. But what is dysplasia now? Dysplasia now is not normal. It is an abnormal proliferation of cells. Proliferation of cells. So what is dysplasia? Abnormal proliferation of cells where there is loss. So what is the abnormality? Number one, there is loss of uniformity of cells. Uniformity. So if you see normal cells, they look so uniform. So they have basal to apical differentiation. They have small NC ratio. They are very uniform, similar looking cells. So they are uniform also. So I should write the word uniform also here. They are uniform also. Okay. So now abnormal proliferations of cells means there is loss of uniformity. Uniformity, that is the uniformity of cell shape and size. Number one, there is loss of uniformity of cell shape and size. Two, there is loss of orientation of cells. Loss of orientation. Orientation of cells. Three, cells now have increased N:C ratio. So now their nuclei have become big. And nuclei have become big. And you know, dysplasia is reversible. It is reversible. Okay, I'll draw dysplasia now. I'll draw dysplastic cells. Now, what do dysplastic cells look like? This is a dysplastic cell. All these are dysplastic cells. These are dysplastic cells. So what has happened? This is abnormal proliferation. The cells have lost uniformity. They have lost their orientation that with respect to each other, and also they have lost that apical to basal to apical differentiation. They have high NC ratio, that is their nuclei have become very big now. Cytoplasm looks less, and however this is reversible. Okay, now you know this dysplasia. If you look at cervix, in cervix you have dysplasia. In cervix, if you look at dysplasia, we divide that dysplasia into 3: CIN1, cervical dysplasia, cervical dysplasia. So if you look at dysplasia in cervix dysplasia, cervical dysplasia is called CIN. What is CIN? Cervical intraepithelial neoplasia. Intraepithelial neoplasia. You have CIN1, you have CIN2, and you have CIN3. Okay, what is CIN1? When these dysplastic cells are only in the lower 1/3 of the epithelium. So dysplastic cells occupy lower 1/3. Lower 1/3. That is CIN1. Second, dysplastic cells occupy 2/3 of the thickness of the epithelium. And CIN3 is dysplastic cells occupy more than 2/3 of the epithelium. More than 2/3 of the epithelium, that is CIN3. So what is dysplasia? In dysplasia, the cells, it's an abnormal proliferation of cells. Cells lose their uniformity with respect to shape and size. So they all become of different shapes and sizes. They lose orientation with respect to each other. They have big nuclei, so NC ratio increases. However, dysplasia to some extent is reversible. Okay. So in cervix, the dysplasia is categorized into CIN1, 2, and 3. If these dysplastic cells occupy only the lower 1/3, that's mild dysplasia or CIN1 or mild dysplasia. If they occupy 2/3 of the epithelium, thickness of the epithelium, that is CIN2 or moderate dysplasia. And if they occupy more than 2/3, that is severe dysplasia. Okay, then we use a term called carcinoma in situ. Carcinoma in situ. So now third term is carcinoma in situ or carcinoma in situ. What is carcinoma in situ? Now, you know, in carcinoma in situ, dysplastic cells occupy the full thickness of the epithelium. So dysplastic cells. So what is CIN3? More than dysplastic cells in more than 2/3. And what is carcinoma in situ? If dysplastic cells occupy full thickness of the epithelium. So dysplastic cells occupy full thickness of the epithelium, So if the dysplastic cells occupy full thickness, okay, Adesh, CIN stands for cervical intraepithelial neoplasia. So the neoplastic cells are within the epithelium. They are confined within the basement membrane. So I'll show you pictures. Okay. So dysplastic cells, what is carcinoma in situ? Carcinoma in situ is when dysplastic cells occupy the full thickness of the epithelium. So that is called as carcinoma in situ. So dysplastic cells occupy the full thickness of the epithelium, but basement membrane is intact. Now carcinoma in situ, this is irreversible. If once it develops, it is irreversible. So it is irreversible and it is pre-invasive. So it is pre-invasive condition and it is irreversible. So when the whole thickness of the epithelium is involved, but the basement membrane is okay, basement membrane is still intact. So if you see this is the basement membrane is intact, but the full thickness is occupied by these dysplastic cells. So if this is the whole thickness is occupied by these dysplastic cells, which have a big nucleus. They have lost their orientation, full thickness, but basement membrane, but they have not yet pierced the basement membrane. So this is full thickness of the epithelium is occupied by this dysplastic cells, but basement membrane is intact. This is called carcinoma in situ. So when the dysplastic cells fill the full thickness of the epithelium, they occupy it, but the basement membrane still remains intact. That is called as carcinoma in situ. This now becomes irreversible and it is a pre-invasive condition, because once these dysplastic cells, they break through the basement membrane and invade down, that will become an invasive cancer. Okay, so fourth now is invasive cancer. Okay, we see. So what is invasive cancer? Now, say invasive cancer is, I'll draw it something like this. So these are dysplastic cells in the full thickness. Like this. And now these dysplastic cells, so, okay, now this is the basement membrane here. Now the dysplastic cells have broken the basement membrane. They break the basement membrane and now they come down, invade into the, like this. So now this is invasive carcinoma. So dysplastic cells, so the abnormal cells which have lost their orientation, dysplastic cells invade the basement membrane. These dysplastic cells, they produce enzymes that break the basement membrane. They produce enzymes like collagenases that break the basement membrane. So they break the basement membrane, and so dysplastic cells, they invade the basement membrane or invade the basement membrane and come into the underlying stroma. So they come into the underlying stroma. So now this becomes an invasive cancer. And last step is metastasis. So cancer cells can metastasize. What is metastasis? Now these cancer cells, on the underlying stroma, there are these blood vessels. This is the blood vessel. Of course, yes, Asha, carcinoma in situ is pre-invasive and it can lead to invasive cancer. So the basement membrane, it is the malignant, the dysplastic or the malignant cells are there, but they are confined by the basement membrane. And these malignant cells, it's irreversible. So these malignant cells will produce enzymes, they will break the basement membrane and come into the underlying stroma and produce an invasive cancer. So that becomes invasive cancer. And then in the underlying stroma, there are blood vessels. So now these malignant cells or these dysplastic cells, they will enter into the blood vessels. So they will enter into the blood vessel. So this is a blood vessel here, and say this is a lymphatic here. So these dysplastic cells now will enter the blood vessels and lymphatics, and this is what is called metastasis. So these dysplastic cells, They have broken the basement membrane, come into the underlying stroma, that becomes an invasive cancer. So these are cancer cells now. These cancer cells, they will go into the blood vessels. They will invade into the blood vessels and go to different organs, that is, or they will invade the lymphatics and will go to different lymph nodes. This is called metastasis. So what is metastasis? Spread of cancer cells to distant organ. So spread to distant organ. So spread to distant organ is metastasis. So spread to distant organ is metastasis. So they go to different organs. So that is metastasis. So these are the terms that you have to understand. Okay, let us look at a picture now. So for better understanding, okay, let us look at the picture here. Okay, first let me see. I have drawn, so you can see the normal cells and dysplastic cells. First picture is showing you normal cells. You can make out the normal cells. This structure is the basement membrane. This is the basement membrane. So you can see the normal cells. They are well oriented. They have small nuclei, lot of cytoplasm. Look at the dysplastic cells. So dysplastic cells have loss of polarity. They show that's an abnormal proliferation. There's loss of cell shape, size, loss of orientation of cells, and they have big nuclei. Okay. Now look at this. Let us see. Picture number 1. This is normal. Look at normal. So you can see the epithelial cell layer. You can see the basement membrane. This pale blue color is the basement membrane. Okay, basement membrane, and this is the stroma here. In the stroma, you can see the blood vessel or the lymphatic. So number 1 is normal. Number 1 is normal. Okay, number 2, this is dysplasia. Dysplasia. Now, what do you see in dysplasia? See what has happened to these cells. These are not normal cells now. These are dysplastic cells, but these dysplastic cells, how much of the epithelium are they occupying? See, these are dysplastic cells which I have labeled. Okay. So these dysplastic cells, they are sitting on the basement membrane. Okay. Then picture number 3, this is carcinoma in situ. Carcinoma in situ. So picture number 3, carcinoma in situ. So dysplastic cells are occupying the full thickness of the epithelium. So these dysplastic cells in full thickness, but still the basement membrane is okay. This is the basement membrane. So this is the basement membrane. Okay, the basement membrane is still okay. Then 4th is invasive cancer. Invasive cancer. So you can see the dysplastic cells now have broken the basement membrane. And 5th is now metastasis. Metastasis. So now this is a blood vessel. Dysplastic cells have entered the blood vessels. They have entered the blood vessels. Okay, so this picture is showing you what is dysplasia. Then carcinoma in situ, full thickness of the epithelium is epithelium shows the dysplastic cells, but the basement membrane is still intact. Once they break these dysplastic cells can produce enzymes which break the basement membrane. Once the basement membrane breaks, now the dysplastic cells break the basement membrane, they come into the underlying stroma. This becomes an invasive cancer. And then in the stroma, there is this pink colored blood vessel. Once they go into the blood vessel, that's called metastasis. They enter the blood vessel or lymphatics, that is called as metastasis. Okay. So that's called metastasis. Okay, now let us see examples in esophagus. You know, esophagus, you can have this dysplasia. So dysplasia, I told you, can be mild. What is mild, moderate and severe? What is mild dysplasia? In cervix, also we can have mild, moderate and severe dysplasia. So mild dysplasia is when the dysplastic cells are in the lower 1/3 of the epithelium. Then when the dysplastic cells occupy 2/3, that is moderate dysplasia, and severe dysplasia is when the dysplastic cells occupy more than the 2/3. So now first you can see the normal stratified squamous epithelium. Second, in mild dysplasia, these lower 1/3. I have labeled dysplastic cells in lower 1/3. Lower 1/3 only. Lower 1/3 of the epithelium, that is mild. Moderate dysplasia, dysplastic cells in 2/3. From more than 1/3, from 1/3 to 2/3. So in 2/3 of epithelium, occupying 2/3 of the epithelium, that is moderate. And severe dysplasia is more than 2/3 of the epithelium is full of dysplastic cells. And if the full thickness epithelium is full of dysplastic cells, that becomes carcinoma in situ. But in all these, if you see, Mild dysplasia, moderate and severe. Here in all these, basement membrane is intact. So more than 2/3 epithelium occupied by dysplastic cells is severe dysplasia. And extreme form of severe dysplasia where full thickness of the epithelium is occupied by dysplastic cells, that is called carcinoma in situ. With the basement membrane still intact, that's called carcinoma in situ. Okay, similarly, that's called carcinoma in situ. Okay. Okay, here again in cervix you have seen this is the normal ectocervix, and here look at this picture. So normal ectocervix. Now this is severe dysplasia, or this is a picture of carcinoma in situ. Carcinoma in situ, full thickness. I'm drawing the arrow. Full thickness is occupied by dysplastic cells, but basement membrane is intact. So in this picture, full thickness is occupied by dysplastic cells. So this is severe dysplasia or carcinoma in situ. So it is full thickness is occupied by dysplastic cells. So that is severe cervical dysplasia, that is CIN3. Okay. Then we'll come to this later. Okay, so that is these are the terms that you have to know. Okay, now if you look at, so these are the features. This is what you call neoplastic progression. Okay, now if you look at the tumors, if you look at tumor nomenclature, how do you name the tumor? So tumor, let us come to tumor nomenclature. How do you name the tumors? Okay, tumor nomenclature. Okay, now how do you name? Now tumors can be benign or malignant. First, let us see this. Tumors can be benign or malignant. Okay, now benign tumors, if you compare benign and malignant tumors, so tumors can be benign or malignant. Benign tumors usually are well differentiated. So benign tumors are well differentiated. What is the meaning of the term well differentiated? Well differentiated means, the term well differentiated means they resemble the tissue from which they arise. So the tumor cells resemble the tissue from which they arise. For example, say you have a lipoma. What is lipoma? Lipoma is a benign tumor of fat cells. Look at the cells in a lipoma. Look at the normal fat cells. They look absolutely similar. So we say lipoma is a well differentiated. It is a benign tumor. It is well differentiated. That is, the lipoma cells and normal fat cells, they look absolutely alike. So well differentiated means the tumor cells resemble the tissue from which they arise. So tumor cells resemble the tissue from which they arise. So this is first feature, that is the benign tumors are well differentiated. They are well differentiated. Second, benign tumors are well differentiated. 1, 2, the benign tumors are well demarcated, or they can be encapsulated. You know, lipoma has a capsule around it. Or even if they don't have a capsule, like a leiomyoma in the uterus, it doesn't have a capsule. It's a benign tumor, it doesn't have a capsule, but it is well demarcated. So they can be well demarcated or encapsulated. 3, benign tumors, they have low mitotic activity. They have low mitotic activity, that is they have slow growth. They have slow growth. They grow very slowly. More mitotic activity means they are growing rapidly. So they have a slow growth. So they grow slowly, and you know, sometimes they will disappear on their own also. So they have a slow rate of growth. So slow growth rate, because their mitotic activity is low. So they have slow growth rate because their mitotic activity is low. 4th, no invasion. So no invasion. They don't invade here and there. No invasion, and no metastasis. No metastasis in a benign tumor. So no invasion and no metastasis in a benign. So they don't invade and they do not metastasize. They do not invade, they do not metastasize. Okay, second, let us come to malignant tumors. Malignant tumors, on the other hand, Differentiation. Okay, malignant tumors can be well differentiated. Even malignant tumors can be well differentiated, but they can be moderately differentiated. They may resemble slightly. They can be poorly differentiated, or they can be anaplastic. So malignant tumors, they can be well or moderate or poorly differentiated. Poorly differentiated. So depends. They can be well, moderate or poorly differentiated, or can be anaplastic. Anaplastic. They can be anaplastic. What does the term anaplasia mean? They can be anaplastic. The term anaplasia, now let me write down here. What is anaplastic? Anaplastic means, anaplasia means complete loss of differentiation. Anaplasia, the term anaplasia means complete loss of differentiation. Loss of differentiation. So, you know, the malignant tumors can be anaplastic, complete loss of differentiation. That is, they do not at all resemble the tissue from which they arise. For example, you are having you have a liposarcoma, which is malignant. Liposarcoma cells may not at all look like normal fat cells. So, you can't even make out that it is a fat tumor. It's a tumor of fat cells. So that is called complete loss of differentiation. So they can be anaplastic with complete loss of differentiation. Second, malignant tumors, they are not well demarcated. Not well demarcated. They are not at all well demarcated. 3, they have a high mitotic activity. High mitotic activity. They have a high mitotic activity, and you know, they have an erratic growth rate. Erratic growth. So they have an erratic growth. Erratic growth means they may grow slowly, then suddenly they will start growing very rapidly. Then they may stop growing, again they will start growing rapidly. So that is erratic growth rate. So they have erratic growth, but by and large they grow rapidly. So, right now they may be growing slowly, but then suddenly they will start growing rapidly. So that's called erratic growth rate. Then they invade. So there is local invasion. Local invasion is there. They will invade into the surrounding tissue, and they will produce metastasis. They will produce metastasis also. So local invasion is there, and they will produce metastasis also. So they will produce metastasis also. So this is difference between benign and malignant tumors. Okay, now how do you name these tumors? How do you name these tumors? So nomenclature. Okay, benign tumors. Benign tumors, you know, benign tumors usually they have suffix oma. Suffix oma. Benign tumors have a suffix oma. Malignant tumors on the other hand, they will have a suffix carcinoma or a suffix sarcoma. So they have a suffix carcinoma or a sarcoma. What is carcinoma? Carcinoma implies, so what is carcinoma? Malignant tumors arising from the epithelium. Epithelium. Malignant tumor that arises from the epithelium is a carcinoma. Malignant tumor that arises from the mesenchymal tissue. Mesenchyme is called a sarcoma. So malignant tumor that arises from the epithelium is a carcinoma. Malignant tumors that arise from the mesenchyme is a sarcoma. So now let us see examples of benign and malignant tumors. So number one, let us see first epithelium. Epithelium. Benign tumors that arise from the epithelium, they are called adenomas, adenoma or papilloma. Papilloma. Adenoma or papilloma. Examples: squamous papilloma, transitional papilloma or adenoma. So what is adenoma? Benign tumor that forms glands is called an adenoma. Malignant counterpart, adenocarcinoma. Adenocarcinoma. So malignant counterpart is adenocarcinoma. Papillary carcinoma. Carcinoma. Then arising from the epithelium, you have squamous cell carcinoma. So carcinoma arising from the squamous epithelium, squamous cell carcinoma. Carcinoma arising from the glandular epithelium is adenocarcinoma. Okay, so this is epithelium. Now let us see examples of mesenchyme. Mesenchyme. Okay, in mesenchyme, number one, fat. Benign tumor of fat is a lipoma. Malignant tumor of fat is a liposarcoma. Liposarcoma. Then benign tumor of smooth muscle is a leiomyoma. Leiomyoma. So leiomyoma is from smooth muscle. Malignant tumor of smooth muscle is a leiomyosarcoma. Malignant tumor of smooth muscle is a leiomyosarcoma. Then skeletal muscle. Benign tumor of skeletal muscle is a rhabdomyoma. Rhabdomyoma. Malignant tumor of skeletal muscle is a rhabdomyosarcoma. Rhabdomyosarcoma is a rhabdomyosarcoma. Then benign tumor of fibrous tissue is a fibroma. Fibroma. Malignant tumor of fibrous tissue is a fibrosarcoma. Fibrosarcoma. Then benign tumor arising from the bone is an osteoma. Osteoma. Benign tumor arising from bone is an osteoma. Malignant tumor arising from bone is an osteosarcoma. Similarly, benign tumor arising from cartilage is a chondroma. Chondroma. Arising from cartilage is a chondroma. Malignant tumor is a chondrosarcoma. Malignant tumor is a chondrosarcoma. Then benign tumor of blood vessels is a hemangioma. Hemangioma. Malignant tumor is an angiosarcoma. Is called angiosarcoma. Malignant tumor is called an angiosarcoma. Then, in the skin we have those melanocytes that produce melanin. So, benign tumor of a melanocyte is a nevus. Nevus is from the melanocyte. And malignant counterpart is a malignant melanoma. Malignant melanoma. So, this is how we give names to benign and malignant tumors. This is the nomenclature of benign and malignant tumors. Okay, other than this, in the chapter of neoplasia, you come across two more terms. You've come across these terms many times. Number one is a hamartoma. Hamartoma. And second is a corystoma. Corystoma. Okay, what is a hamartoma? Okay, what is hamartoma? Normal tissue where it should be there. Where it should be. Normal tissue, normal in the right place. Right tissue in the right place, but with a disorganized arrangement. So, disorganized overgrowth of tissues in their native location. So, what is a hamartoma? Disorganized overgrowth. Overgrowth. So, it's an overgrowth, but disorganized overgrowth of tissues in their native location. So, wherever the tissue should be, it is there in the right place. But there is a disorganized overgrowth of the tissue in the place. So, example of a hamartoma is, we have hamartomas in the bronchus. If you look at a bronchial hamartoma, it's an overgrowth in this overgrowth you will have whatever the normal bronchus has. All those things will be there. So, normal bronchus has cartilage. Normal bronchus is lined by ciliated columnar epithelium. Normal bronchus has smooth muscle. So, all those things will be there in a bronchial hamartoma, but they will be arranged in a disorganized fashion. So, example, bronchial hamartoma. Bronchial hamartomas. Hamartoma 1. 2. Peutz-Jeghers polyps. Peutz-Jeghers polyps. So, these are polyps in the GI tract. Peutz-Jeghers polyp. They are disorganized overgrowth of tissue, of intestinal tissue, of normal intestinal tissue, which you call Peutz-Jeghers polyp. So, that's a hamartoma. Okay, second entity is a corystoma. What is corystoma? Normal tissue gets up and goes and sits in some wrong place. So, normal tissue in abnormal location or in foreign location. So, normal tissue in foreign location. That's called a corystoma. Normal tissue in foreign location. Example, people with Meckel's diverticulum. In the Meckel's diverticulum, you can have gastric tissue or pancreatic tissue. So gastric or pancreatic tissue in Meckel's diverticulum. Okay, now what is Meckel's diverticulum? It is in the small intestine. It's in the ileum, located in the ileum. So gastric or pancreatic tissue comes and sits in the Meckel's diverticulum. So that is a porous tumor. Okay. Now, if you look at malignant tumors, we just saw malignant tumors of epithelial origin are called carcinomas. Malignant tumors of mesenchymal origin are called sarcomas. Now, if you look at malignant tissues, in malignancy, we do something called as tumor grade and tumor stage. So, for malignant neoplasms, for malignant tumors, we do something called as grading and staging. So in malignant tumors, what do? We do something called as grading. So in malignant tumors, we do something that we call as grading and staging. Okay, now what is this grading? Grading is done on histology. So it's the histological assessment of the tumor. And what is this histological assessment? Histological assessment of how well differentiated the tumor is. So histological grading is degree of, so it is a histological assessment, number one. So pathologist will do it. Histological assessment. And what does it tell you? It gives you information regarding the degree of differentiation of tumor. So it tells you about the degree of differentiation, degree of differentiation and mitotic activity of tumor. So it will tell you how well differentiated, it will tell you whether the tumor is well differentiated, moderately differentiated. The pathologist is going to tell you, oh yes, the tumor is well differentiated. It's a malignant tumor but well differentiated, or it's moderately differentiated, or it's poorly differentiated, or it's anaplastic, that is complete lack of differentiation. And they will also comment on, tell you about the mitotic activity. So if there are too much mitotic activity, that means the tumor is multiplying very fast. So that is grading. Grading is basically histological assessment done by a pathologist by looking at the tumor under the microscope, and that is, they tell you about the degree of differentiation of tumor. And mitotic activity. So tumors are divided into well differentiated. Well differentiated tumors are low grade. They are low grade tumors. So they are low grade. So they will have a better prognosis. Then you have moderately differentiated, poorly differentiated. Okay, poorly differentiated tumors are high grade. Poorly differentiated, which are high grade. Poorly differentiated, moderately differentiated are intermediate grade. And poorly differentiated, or what you call as, or undifferentiated, for which we use the term anaplastic. They are high grade tumors. And this grading is it's a prognostic factor. It has prognostic value. Okay, so high grade tumors which are anaplastic, poorly differentiated, they will have a poorer prognosis as compared to well differentiated or low grade tumors. So high grade tumors have a poor prognosis. So this is grading, which gives you information about the prognosis of tumor. Okay, second is the stage of tumor. Okay, second is the stage. Okay, what is the staging? Staging is, we use TNM staging. We use this TNM staging is there. Okay, what is T? T stands for tumor size. So T is for tumor size. Okay, so T will tell you about the localization. It will tell you about the tumor size and localization. So T of TNM staging, T stands for tumor size or localization or spread. of tumor. So localization oblique spread. N stands for, whether the N is node. So spread to regional lymph node. So N will tell you about spread to regional lymph nodes. Lymph node. So whether the tumor has gone to the regional lymph node. So N staging will tell you that. And M is presence of metastasis. Tells you about presence or absence of metastasis. So it will tell you about presence or absence of metastasis. So that is TNM staging. That is called TNM staging. And now this TNM staging, you know, the grade is done by it is the histological assessment. So this is done by a pathologist. So it is pathology. It is done by pathologist. Whereas TNM staging, this is based on number one, clinical. So clinical assessment. Two, pathology. Clinical assessment. It is done on based on clinical assessment, radiological. Clinical, radiological, and even pathological assessment. So clinical, radiological, and pathological assessment. Okay. And now very important point. Grading is also a prognostic factor. TNM staging is also a prognostic factor. Always remember, so both are prognostic factors. Stage has more prognostic value than grade. So stage has almost always, I'm using the word almost always more prognostic value than stage. So grade almost always has more prognostic value than stage. And each, in TNM, each, T, N, M. What is T? T is tumor size and localization, oblique spread. N is nodal involvement. Each T, N, and M factor has independent prognostic value. So all these, tumor size has a prognostic value, node has a prognostic value, M has a prognostic value. So each has independent prognostic value. Each of these factors, T, N, and M, has independent prognostic value. M factor often most important. M is most important. Why? Because M tells you now the tumor has spread far and wide. So each of these three has an independent prognostic value. And again, very important, I reiterate, staging is always more important than grading, almost always. There are one or two exceptions to this. So staging has always more important prognostic value. Okay, first example, what do I mean by staging has more important prognostic value? Example, high stage. Say you have a low grade tumor but high stage. Then this has, so low grade tumor, low grade but high stage has worse prognosis than high grade but low stage tumor. So low grade but high stage tumor has worse prognosis than high grade but low stage tumor. Okay. So this is grading versus staging. Okay. Now, as I wrote, stage almost always has more prognostic. So staging is more important than grading. However, there are one or two exceptions where grading is more important than staging. Exceptions where grading is more important than staging. So grading is more important than staging. This is in brain tumors. So this is in where grading is more important. Number one, brain tumors or gliomas. So brain tumors or gliomas, grading is more important than staging. Then NHL, non-Hodgkin's lymphoma. In NHLs also, again, grading is more important. And then soft tissue sarcomas. And also remember Wilms tumor. In Wilms tumor histology, Wilms tumor, anaplasia, presence of anaplasia is a very important prognostic factor. So in Wilms tumor, look for anaplasia. If anaplasia is there in Wilms tumor, then that Wilms tumor will have a poor prognosis in Wilms tumor. Okay, so now this is about grading versus staging of the tumors. Okay, now let us look at the, okay, so now next important part is I have to cover hallmarks of cancer. Okay, but before hallmarks, let me quickly finish some simple things. There is something called carcinogens. So I'll cover carcinogens and I will talk about, so let us talk about carcinogens. Carcinogens first. Okay, what are carcinogens? Cancer causing agents. So agents that can cause cancer. Okay, so now carcinogens can cause cancer. So carcinogens can be chemical carcinogens. Chemical carcinogens. What are chemical carcinogens? Chemicals that can cause cancer. Then we have radiation. Radiation can cause cancer. So chemical carcinogens, radiation can cause cancer, and you have microbes. Microbes that can cause cancer. Microbes, that is oncogenic microbes. And then third we have oncogenic microbes, which can cause cancer. So microbes can cause cancers, chemicals can cause cancers, they are chemical carcinogens, and radiation like ultraviolet light or radiation like ionizing radiation, they can also cause cancer. Okay, first let us see names of few oncogenic microbes. Let's see names of oncogenic microbes. So microbes that can cause cancer. Okay, microbes that can cause cancer, very important. So you have to know EBV. What is EBV? Epstein-Barr virus. Epstein-Barr virus. Which are the cancers that EBV can cause? Epstein-Barr virus is associated, number one, with Burkitt's lymphoma. So EBV associated cancers are, number one, Burkitt's lymphoma. Number two, Hodgkin's lymphoma. So EBV is associated with Hodgkin's lymphoma. Number three, nasopharyngeal carcinoma. Nasopharyngeal carcinoma. So EBV causes nasopharyngeal carcinoma. Then primary CNS lymphoma. CNS lymphoma is associated with, so primary CNS lymphoma in immunocompromised. So primary CNS lymphomas in immunocompromised, they are associated with this virus, that is Epstein-Barr virus. Second, hepatitis B virus and hepatitis C virus. Hepatitis B and C viruses, they are associated with hepatocellular carcinoma, liver cancer, hepatocellular carcinoma. So hepatitis B and C viruses, they are associated with hepatocellular carcinoma. Okay, third, human herpes virus 8, HHV8. What is HHV8? Human herpes virus 8. It is also called Kaposi sarcoma herpes virus 8. Kaposi sarcoma, KS stands for Kaposi sarcoma herpes virus 8. This is associated with Kaposi sarcoma, causes Kaposi sarcoma. So human herpes virus 8 causes Kaposi sarcoma. Very, very important. HPV. What is HPV? Human papilloma virus. Human papilloma virus. Human papilloma virus, carcinoma cervix. So CA cervix, carcinoma associated with carcinoma cervix. Then penile and anal cancers. Penile and anal cancers. Anal cancers. And also head and neck cancer. So penile and anal cancer and also head and neck cancer. Penile and anal cancer and head and neck cancer. Then very, very important, a bacteria called H. pylori. What does H. pylori stand for? Helicobacter pylori. H. pylori stands for Helicobacter pylori. Gastric adenocarcinoma. So it is associated with adenocarcinoma stomach plus a lymphoma of stomach called maltoma stomach. Maltoma stomach. What is maltoma stomach? It's a lymphoma. It's a lymphoma occurring in the stomach. So that is H. pylori. Then another oncogenic microbe is a virus called HTLV1. What does HTLV1 stand for? Human T cell leukemia virus. What is HTLV? Human T cell leukemia virus. Human T cell leukemia. This causes adult T cell leukemia. Adult T cell leukemia, lymphoma. So it can cause leukemia, or that, I mean, it can have a lymphoma counterpart also. So then liver fluke. Liver fluke. Liver fluke is also called Clonarchus sinensis. So liver fluke is associated with cholangiocarcinoma. Liver fluke causes cholangiocarcinoma. 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 What is cholangiocarcinoma? Bile duct. Cancer arising from the bile ducts is a cholangiocarcinoma. Cancer arising from the bile ducts is called a cholangiocarcinoma. Cancer arising from the bile ducts is cholangiocarcinoma. So cancer arising from the bile ducts. Okay, Adesh, you want to see the previous slide? Okay, from where? Okay, oncogenic microbes. So I'm talking about oncogenic microbes. So Epstein-Barr virus is associated with Burkitt's lymphoma, Hodgkin's lymphoma, nasopharyngeal carcinoma, and primary CNS lymphomas. Then hepatitis B and C viruses, they cause liver cancer, hepatocellular carcinoma. Then human herpes virus 8, which is also called Kaposi sarcoma herpes virus 8. It causes Kaposi sarcoma. Then HPV virus. What is HPV? Human papilloma virus. It causes carcinoma cervix, penile and anal cancer, head and neck cancer. Then H. pylori, which is a bacteria, Helicobacter pylori, causes adenocarcinoma stomach and maltoma stomach. What is a maltoma? Maltoma is a lymphoma of stomach. Then HTLV1. What is HTLV? Human T cell leukemia virus 1. This causes adult T cell leukemia. It can be leukemia and lymphoma. Adult T cell leukemia, lymphoma. Then liver fluke. Liver fluke causes cholangiocarcinoma. Liver fluke causes cholangiocarcinoma. And last is schistosoma hematobium. Schistosoma hematobium. Schistosoma hematobium. This causes bladder cancer. Bladder cancer. So schistosoma hematobium, it causes bladder cancer. Which bladder cancer? Squamous cell carcinoma. So schistosoma hematobium, it causes bladder cancer, squamous cell carcinoma of the bladder. So it causes squamous cell carcinoma of the bladder. Okay. So these are oncogenic microbes. Okay, oncogenic microbes. Now let us come to the chemicals that can cause cancer. So let us come to chemical carcinogens. Okay, let us look at chemical carcinogens. Okay, now let us come to chemical carcinogens. In chemical carcinogens, number 1, aflatoxin. Okay, aflatoxin actually is not a chemical. It is like an organic chemical. Aflatoxin, you know, aflatoxin is produced by fungus Aspergillus. Aspergillus. So it is produced by the fungus Aspergillus. And you know, where does this fungus grow? in the grain and the nuts that have been stored. So it grows in stored grain and nuts. So stored grain and nuts, aspergillus can grow in them. And aspergillus causes liver cancer, hepatocellular carcinoma. So exposure to aspergillus occurs in stored grain and nuts. So in the stored grain and nuts, this fungus grows and this fungus produces this aflatoxin, and when you consume the stored grain and nuts, this aflatoxin can cause hepatocellular carcinoma. Okay, second is alkylating agents. Alkylating agents. Okay, alkylating agents are a part of chemotherapy. Exposure occurs people who are on chemotherapy. So exposure is when cancer patient is given immunotherapy. They are given chemotherapy for cancer. So alkylating agents now can, say breast cancer patient is given, for example, chemotherapy, they can develop later on, may develop leukemias or lymphomas. So alkylating agents can produce leukemias and lymphomas. Lymphoma, alkylating agents. Okay, 3. Third is aromatic amines. Aromatic amines. So third is aromatic amines. So third is aromatic amines. Okay, Sridevi, hepatocellular carcinoma is long term. Okay, these cancers will not, this is not acute. Okay, aromatic amines like naphthylamine. There's something called as beta naphthylamine. Aromatic amines like beta naphthylamine. So aromatic amines like beta naphthylamine. Exposure to aromatic amines usually occurs in textile industry. Textile industry, dyeing, like dye industry where dyes are used, or in tobacco smoke. Tobacco smoking also, you know tobacco smoking has so many carcinogens in it. One of them is aromatic amines. Okay, so now these aromatic amines, they cause bladder cancer, urinary bladder cancer. So they cause bladder cancer. So aromatic amines exposure occurs in textile or industry like the dyeing industry and in tobacco smoke also. So aromatic amines cause bladder cancer. Then arsenic. Okay, exposure to arsenic occurs when using herbicides. Herbicides which are used in wine. Herbicides are used. So vineyard workers can be exposed to arsenic. Also in metal smelting. In metal smelting also arsenic exposure to arsenic occurs. And arsenic can cause cancer at number of sites. So arsenic can cause, number 1, in liver, arsenic can cause angiosarcoma of liver. So arsenic can cause cancer at a number of sites. Second, arsenic can cause lung cancer. So it can cause lung cancer. And 3, arsenic can also cause skin cancer. It can cause squamous cell carcinoma skin. So arsenic exposure can cause cancer in the liver, lung and skin. And arsenic exposure occurs in people who are working in the vineyard workers who are exposed to herbicides, or in metal smelting industry. Arsenic exposure can occur. Okay. Then next is asbestos. Okay. Asbestos exposure occurs in shipyard workers. So in shipyard workers, and old roofing material also has asbestos. Old roofing material. So old roofing material. And this arsenic, it can cause lung cancer. So arsenic can cause, number 1, 2 cancers. Number 1, mesothelioma, and 2, lung cancer. So it can cause mesothelioma as well as lung cancer. So mesothelioma and lung cancer. Okay, that is asbestos. Then carbon tetrachloride. Carbon tetrachloride. Carbon tetrachloride. So carbon tetrachloride. Okay, now carbon tetrachloride doesn't cause cancer. It can cause CCl4 poisoning. So in the liver, carbon tetrachloride can cause fatty liver, and also it can cause what you call as, around the central vein. The central vein is in the center of the lobule. The hepatocytes around the central vein can undergo necrosis if there is exposure to carbon tetrachloride. So centrilobular necrosis. No tumor here, centrilobular necrosis. Okay, so actually you can remove it from here because I'm talking about carcinogens. This is not about carcinogen. Okay, carbon tetrachloride. Okay, very, very important now, cigarette smoke. Cigarette smoke. Okay, now cigarette smoke has so many carcinogens, and cigarette smoke is associated with so many cancers. So very important, the cancers associated with cigarette smoke are: number one, bladder. In the bladder, cigarette smoke causes TCC. What is TCC? Transitional cell carcinoma bladder. Bladder is lined by transitional epithelium. Urinary tract is lined by transitional epithelium. Cancer that arises from transitional epithelium is transitional cell carcinoma. Then in the cervix, bladder causes cervical cancer. Cervical cancer. Esophagus. Bladder cigarette smoke can cause esophageal cancer. It can cause squamous cell carcinoma or adenocarcinoma in the esophagus. Any of these types. Then very important, kidney. In kidney, again renal cell carcinoma. RCC means renal cell carcinoma. Then it can also cause laryngeal or oropharyngeal CA. So laryngeal cancer, oropharyngeal. Lung cancer. In lung, cigarette smoke is associated with number one, squamous cell carcinoma, and two, small cell carcinoma. Small cell carcinoma. So these are two histological types, squamous cell carcinoma and small cell carcinoma. So that is lung cancer. And even pancreas. Pancreas, it can cause pancreatic adenocarcinoma. Pancreatic adenocarcinoma. So cigarette smoking is associated with so many cancers because cigarette smoke has so many carcinogens in it, and it can cause so many cancers. That is cigarette smoke. Then alcohol, ethanol or alcohol. Ethanol can cause, number one, ethanol can cause esophageal cancer, esophageal CA. Two, liver cancer, hepatocellular carcinoma, and three, also associated with carcinoma breast. So ethanol can cause esophageal cancer. Which cancer of the esophagus? Squamous cell carcinoma, SCC, squamous cell carcinoma. Okay, Sridevi, you found the very right number. 7,000 chemicals and 16 cancers. Oh my God. Okay, so ethanol can cause squamous cell carcinoma of esophagus, hepatocellular carcinoma, also associated with breast cancer. Okay, then nitrosamines. Okay, where do you find these nitrosamines? Nitrosamines, they are found in smoked foods. They are found in smoked foods. So nitrosamines can cause stomach cancer. So nitrosamines are found in smoked foods. They can cause stomach cancer. Then we have vinyl chloride. Now, vinyl chloride, this is used in PVC pipes. So PVC pipes containing So used in PVC pipe, vinyl chloride is used in PVC pipe, and vinyl chloride is associated with angiosarcoma of liver. It's associated with angiosarcoma of liver. Then next, radiation. Very important is radiation. Radiation can cause cancer. Okay, in radiation we have ionizing radiation. Ionizing radiation. So ionizing radiation. Ionizing radiation can cause, number one, papillary carcinoma thyroid, associated with papillary exposure to ionizing radiation. Papillary carcinoma thyroid. Two, all leukemias except CLL, chronic lymphocytic leukemia, they are associated with ionizing radiation. Also carcinoma breast. Then ultraviolet light, UV radiation. You know, UVB is most carcinogenic. UV radiation. UV light can cause skin cancers. In the skin cancers, you have squamous cell carcinoma, basal cell carcinoma, and melanoma skin. So all three can be caused by ultraviolet light. Okay, so they all three can be caused by ultraviolet light. Okay, now few lines on metastasis. Let us come to few lines. I want to tell you about metastasis of tumor. So malignant tumors, you know, they metastasize. What is metastasis? Metastasis is, as we saw, what is metastasis? Spread of tumor to distant site. So what is metastasis? Spread of tumor to distant site. So spread of tumor to distant sites. That is called metastasis. Okay. So metastasis, the tumors can metastasize via lymphatics. So metastasis can occur via lymphatics. So tumors can spread via lymphatics. By tumor cells, malignant tumors, the tumor cells can invade into lymphatics and then spread, or through blood vessels. That is hematogenous spread. So lymphatic spread or hematogenous spread. Okay, now, you know, most carcinomas, so very important, most carcinomas spread via lymphatics. So, you know, the carcinomas, they like to spread via lymphatics, and most sarcomas spread via hematogenous route. Most sarcomas spread via hematogenous route. So most sarcomas, they like to spread via hematogenous route. Carcinomas, by and large, they like to spread via lymphatic route. Now, most sarcomas spread via hematogenous route. Now, there is some exception. There are 4 cancers also. Most sarcomas spread via hematogenous route, plus 4 carcinomas also. They prefer a hematogenous route. Which are these 4 carcinomas? They are hepatocellular carcinoma, that is liver cancer, renal cancer, kidney cancer, that spreads via the renal vein. Third, choriocarcinoma, and fourth is follicular carcinoma thyroid. So these tumors, these are 4 carcinomas which first prefer a hematogenous route rather than a lymphatic route. Otherwise, by and large, carcinomas like to spread via lymphatics and sarcomas like to spread via hematogenous route. Okay, now when they spread, you know, whether they spread via lymphatics or hematogenous route, where will they go? The target organ where they spread, you know, the target organ actually will be the first encountered capillary bed. So the target organ, so say the tumor, there's a carcinoma, squamous cell carcinoma, it wants to spread via the lymphatics. Or say there's a hepatocellular carcinoma, it wants to spread via hematogenous route. So target organ is often the first encountered capillary bed. So target organ is often the first encountered capillary bed. So the tumor will spread to the first encountered capillary blood. And where will the, most of the blood, our blood goes to the lungs, or from the GI tract, most of the blood will go to the liver. So the first encountered capillary bed examples are liver, 2 lungs, then bone, brain, etc. These are the commonly encountered capillary beds. And remember, most common sites of metastasis are number 1, lymph node. Lymph node, most common site of mets, followed by lung and liver. These are second most common site for mets are lung and liver. And then you have bone and brain as well. Okay, now let us see. First, let us see liver. If you look at liver and lung are most common site of metastasis after the regional lymph nodes. So regional lymph nodes, I should use the word regional. Regional lymph nodes are the most common site of mets, followed by that liver and lung. Okay, liver. From where do, most of the GI tract blood goes into the liver. So GI tract cancers usually metastasize to the liver. So in the liver, most common colon cancer comes to the liver, followed by stomach, followed by pancreas. So if you are having a liver mets, think of colon, stomach and pancreas. So the primary tumor is in the colon, stomach or pancreas. So primary tumor, colon, stomach or pancreas. Okay, liver. Okay, second, another site is brain. Okay, brain. Okay, brain. Okay, which are the tumors that okay, Sridevi, you have asked me breast after lung. No, breast is not a site for metastasis. See, what I am talking about is site for metastasis. So, if there are metastatic deposits in the liver, where can the primary tumor be? In the colon, stomach or pancreas. Second, if there are metastases in the brain, from where do brain mets come? Brain mets come from lungs, breast. So breast cancer can produce metastasis. Brain is not a common site for metastasis. Common sites for metastasis are number 1, lymph nodes, number 2, liver, number 3, lung, number 4, brain and bones. These are common sites for metastasis. Okay. Achha. Now from where can, if a person has metastasis in the brain, think of lung, breast. So what do you think of lung, breast, melanoma? Then even colon and kidney can produce brain mets. So colonic cancer and kidney cancer can produce brain mets. And if there are mets in the brain, usually mets in the brain are brain mets occur at gray-white junction. So they are metastasis in the brain will occur at the junction of gray and white matter. And brain mets, they occur at number 1, they occur at junction of the gray and white matter, and they are brain mets are multiple and well circumscribed. So brain mets, they occur at gray-white junction of the brain, at the junction of gray matter with white matter, and they are multiple and circumscribed. So that is brain. And then another site of metastasis is bone. Okay, now in bone, metastasis are more common than primary bone tumor. So metastasis more more common than primary brain tumors, primary bone tumors, primary bone tumors. So METs are more common in the bone than the primary bone tumors. And now, we divide metastasis in bone into three categories. Those that produce lytic lesions. Lytic means bone destructive. So metastatic deposits, they cause destruction of the bone. They are lytic. They are called as lytic. So which are the tumors that produce lytic bone lesions? They are thyroid cancer. Thyroid cancer can produce lytic bone lesions. Kidney, renal cell carcinoma, kidney. And 3, non-small cell carcinoma lung. Cell carcinoma lung. They produce lytic lesions in the bone, that is just bone destructive. Second type of bone mets are blastic. Blastic means bone forming. So metastatic deposits, the tumor cells start forming the bone. So bone forming, or there is bone formation around the tumor cells, happens around the tumor cells. This is seen in case of prostate cancer. So if prostate cancer produces metastatic deposits in the bone formation will occur. So that is prostate and small cell carcinoma. Small cell carcinoma lung. So if small cell carcinomas from the lung produce blastic secondaries or blastic metastatic deposits. And then third is mixed. Mixed is both lytic and blastic. This is seen in case of carcinoma breast. If it produces bone mets, they are combined lytic and blastic. And metastasis in the bones are in the bones of axial skeleton. So mets, they have predilection for axial skeleton. So metastatic deposits, they have predilection for what you call as, they have predilection for axial skeleton. So they have predilection for axial skeleton. Okay, so now I'll be stopping here. Okay, now I have covered half of neoplasia. Okay, so now Sridevi, you were asking me, this is end of general pathology. No, I have covered half of neoplasia. Now what else do I have to cover? Number 1, I have to cover tumor markers from this chapter. Number 2, I have to cover what you call as paraneoplastic syndromes from this chapter. And 3, very, very important, I have to cover hallmarks of cancer, in which I will be telling you about oncogenes and tumor suppressor genes. So I'll be talking about oncogenes. So that part is left in neoplasia. Okay. So now if you have any questions, you can ask me. If you've not understood any part or you want me to repeat anything, you can tell me. I mean, you can ask me, I can repeat it. Any questions? Anyone has any questions? Okay, so in the next class, we'll finish neoplasia and I'll start with systemic pathology. Most probably, I'll start with GIT. Okay, so I will finish neoplasia. That is going to take some time. Okay, Asha, I think the next class is on Thursday. Next class is on Thursday. If I'm not mistaken, it is on Thursday. Okay, so good night, all of you. Good night, all of you, and please read up whatever I have covered. Okay. Okay, Sridevi, thank you so much. And I see you are studying also well. Okay, so good night to all of you. Good night to all of you. Okay.